everyone. Thank you for being here. My name is Rachel Goodman, and I am a current first-year cardiology fellow at Tufts. I have an interest in heart failure and critical care, and I'm excited to be here today as a CardioNerds Conference Scholar for the upcoming Cardiac Critical Care Education Summit at the University of Minnesota with mentorship from Yoav Karpenshif.
Thanks, Rachel. I'm Yoav Karpenshif. I'm a critical care cardiologist and assistant professor at the University of Pennsylvania. I'm also a proud CardioNerd and the chair of the CardioNerds Critical Care Cardiology Committee. I am also on the executive planning committee for the upcoming Critical Care Educational Summit at UMN. I am so excited today to introduce Drs. Andrea Elliot and Cameron Dezfulian. I'll start off with Dr. Andrea Elliot, who is an associate professor of medicine at the University of Minnesota, where she works as a critical care cardiologist. She's also associate program director for the General Cardiology Fellowship and the program director for the Critical Care Cardiology Fellowship. Dr. Elliot is a thought leader in the world of critical care cardiology. She has a research focus in eCPR. She's the director of the upcoming Critical Care Cardiology Education Summit at the University of Minnesota. Dr. Elliot, thank you so much for joining us today.
Thank you guys for inviting me. It was a great introduction, and I'm actually equally thrilled to be here today.
And I also want to introduce Dr. Cameron Dezfulian. He's a senior faculty in pediatric critical care medicine and adult anesthesia and critical care at Baylor College of Medicine, and the medical director of the adult congenital heart ICU at Texas Children's Hospital in Houston. He's trained in both pediatric and adult critical care medicine and works primarily in the new cardiac and cardiothoracic ICUs at Baylor. His research spans the bench to bedside and is focused on the signs of organ damage after cardiac arrest. Thanks for being here, Dr. Dezfulian.
Hey, thank you guys for having me. Really happy to talk about this topic.
So thank you again. We are so happy to talk with you today, and I think let's get started. Dr. Dezfulian, first a question for you. Can you share with us a little bit about your career journey and how it led to you having this niche of taking care of critically ill patients with ACHD?
Well, so as you guys mentioned, I'm a med peds trained person, and coming out of med peds, I loved the ICU. So I really wanted to do critical care, and I wanted to do both of them, which there's a small number of us in the country. I actually think I get emails from almost all of them because they ask me, like, is this worth doing? Should I go this path? And to be honest with you, I thought it was mostly just interesting, and so I did it. I can't say that the med and the peds necessarily helped one another beyond all being critical care. But then when I was offered this opportunity with adult congenital, that was the first time that I saw how like there was a strong overlap, which was really cool, and is ultimately what led me here to Texas. So, you know, adult congenital definitely is a specialty that spans that whole gamut. And I think having an adult congenital unit is a pretty unique thing and allows you, from an ICU perspective, to really use your peds congenital knowledge and as well as your adult, cardiac critical care knowledge.
After last year's success, we're gearing up for the second annual Cardiology Critical Care Educational Summit, which all of us will be at. Dr. Elliot, this year's conference has a focus on ACHD. Why is it important for critical care cardiologists to have comfort taking care of patients with ACHD?
Oh, that's a great question. So I can attest from firsthand experience that ACHD patients who end up in the ICU for any reason, whether it's because they have a primary cardiac problem or they had a motor vehicle accident, they are the most complex patients that I see on average. They, they require special expertise and thought, like a special thoughtful management and awareness of these unique risk profiles that they're going to have and their special specific hemodynamic profiles. So, we marry training in cardiology with our education in critical care every day as critical care cardiologists. We do that for all of our patients, but these patients in particular require even more thoughtful approach and a recognition of the nuances of their specific hemodynamic profiles. And so we thought this would be a good way to help bring even more layers of complexity to the cardiac ICU and to those people that are practicing there.
So along those lines, as patients with ACHD live longer, I suspect that we'll see a rise in the number of patients with ACHD in the cardiac ICU. So Dr. Dezfulian, who are the right team members that should be involved in taking care of these patients?
Yeah, I mean, so first of all, that's a great point, Rachel, in that the numbers, they do keep increasing because of our success. So, the last estimate in 2010, there was a circulation article that looked at this 1.5 million adults with congenital heart disease versus 1 million pediatrics. So already more adults than kids, but the reality is those numbers have continued to grow. And there's probably, if you just go by the growth of the population, all somewhere around 2.5 million now adults with congenital heart disease. Now, maybe a third of those have complex disease, and it's really that complex group that I think needs the really focused specialty care, because they don't have straightforward disease. Their anatomy is abnormal. With that, the kind of the function and physiology that goes with that is abnormal and really requires some thought. You can't, not only is it thought from, say, a surgical perspective, because these are redos, and we have a number of 5 and 6 time redo operations. So there's tremendous surgical planning that goes into that. But then also what's going to happen when you do something that normally you would think of as trivial, like replacing a incompetent valve, is actually pretty dramatic when you're dealing with somebody, for example, as Epstein's and or tetralogy, and really you can precipitate things that you would not expect in other scenarios. And so I think it does take a lot of kind of forward planning, and as opposed to in the regular cardiac ICU where I don't talk with my surgeons about their approach to a cabbage or a valve. We don't do a whole lot of forward planning. Every single patient that we bring for an operation gets a multidisciplinary discussion with about 20 people on a call, including cardiologists, intensivists, surgeons, and people from the cardiology side who are expertise in EP as well as interventional, to look at all the angles of how we could optimize the function going through this. And I think that's warranted because of the complexity that you're dealing with and some of the really post-op complications that are far more intense and potentially fatal than they would be on your average heart that's a first-time valve or cabbage.
Dr. Elliot, what are some of the most common reasons that you see patients with congenital heart disease end up in the CICU?
Well, I think I break this down into 2 groups based on at least my experience. I think there's those that are generally thriving and have normal underlying physiology, or at least are functioning as such, and they're doing okay after whatever repair they had, and then they get ill for something from some other reason, whether it's COVID, pneumonia, sepsis, like I mentioned, the motor vehicle accident, they develop ARDS from pancreatitis or whatever it is, and that baseline physiology is so much more fragile, they end up being super, super sick. And that means our usual approach to care for these common conditions has to be modified, because these people are so sick from and have unusual hemodynamics that we're not seeing in even just those patients that have heart failure. And then there's a second group of people that come in because their heart's failing, whether it's because they're having complications from their repairs, or they're presenting postoperatively after a surgical intervention for a failing repair. And I think those patients have their own unique challenges and complexities too, just as Dr. Dezfulian was mentioning. So I kind of break them down in those 2 specific groups. I specifically work in a unit where we have a lot of post-cardiac arrest patients, and so a lot of my patients will have are having failing operative repairs, and then they've arrested, and so I'll see a lot of them with temporary mechanical support, and that's where I'm seeing them most of the time. But all of these scenarios are going to be specifically addressed during different didactics and some hands-on sessions during the conference. So come and hear more.
I'm very excited for those. Dr. Dezfulian, as a med-peds trained physician, I imagine you have seen patients with congenital heart disease at various stages of their disease course. Are there differences in the approach to the care of patients with congenital heart disease at pediatric versus adult hospitals? And are there opportunities for us to learn from each other?
Yeah, I mean, that's a great question, and you're absolutely right. I mean, there's some significant differences, and I think a lot of learning opportunities. I think that from the if I put on my pediatrician hat, you know, first of all, our expectation is every patient should live, right? That's not always the expectation on the adult side, right? I mean, I think just because of the patients we take care of, we deal with mortality, right? And it's just a fact of life. And there's a certain segment of the population that even if we try our best, they're going to not make it through. And there's a bit of an acceptance of that sometimes leads to just maybe putting up your hands and saying, perhaps we haven't, you know, we've pushed too much, we should just stop now. That doesn't happen in pediatrics, right? We push and we push and we push. And what's remarkable to me is here, given that I work at Texas Children's Hospital and that attitude is very much present as a children's hospital, I have seen some unbelievable success stories, but they've required months of critical care, and they've required kind of a dedication that you wouldn't see in most adult centers, right? And that includes the places I've worked, and certainly my perspective has changed about what the human body can handle and what's worth pushing for, because, you know, all of our patients have gone home functional. So it's not, you know, we're not, fortunately, we're in cardiology, we're not in neurology, right? We're not sending home vegetative states, right? We're sending home really fully functional people after we rehab them and get them better. From the adult side, I think the volume we see is tremendous, and you know, the fact that we do a lot of mechanical circulatory support and using advanced monitoring like PA catheters and various devices that have been well validated within the adult population, but not so much pediatrics. Those are valuable things to allow us to recover our patients. And so most pediatric hospitals don't have a big depth of experience with mechanical circulatory support. Texas Children's, I think, is exceptional. There's a couple other big centers, you know, CHOP, Harvard, where the numbers are tremendous. And so they do mechanical support regularly. But most smaller pediatric centers, it's a limited number, and they don't necessarily think about going on as quickly as I think we now do in the adult side, right? When we recognize kind of a failing heart, and this is, you know, we're heading towards an arrest, and this is now going, you know, from sky 4 to 5, and we need to move, and we do move. And I think that recognition is really helpful. So those are just a couple examples, but I think there's actually a lot out there that we can learn from the disciplines from one another.
That's so very interesting, and I can't wait to learn even more from you at this conference. Dr. Elliot, critical care cardiology is a relatively new field, but more and more trainees are expressing interest in joining us. Why is it important to have a conference that focuses on the education in critical care cardiology?
Yeah, I could spend hours talking about this specific question. So thank you for giving me my soapbox for a minute. But I think the real reason that we set about putting this conference together is that we think it's really important to bring like-minded people who are excited about bringing critical care principles and best practices into the cardiac ICU or CV ICU together. And so that trainees can see that what's being done in this field and understand the importance and utility of getting additional training in critical care. And so they can fully realize that that extra training allows them to bring something to the table that enhances the care of those critically ill patients, and also to our colleagues in cardiology who, you know, have spent their time and dedicated their life in training in a unique subspecialty, but haven't had that exposure and education in critical care yet. So, you know, this conference is dedicated to the critical care skills that aren't traditionally seen in cardiology fellowship. So we, you know, you can go to AHA, ACC, among many other great conferences in cardiology, but it's hard for cardiologists to imagine what are those skills that they could also learn about and be doing in the cardiac ICU. So we focus on critical care skills in small groups right alongside the faculty from all across the country. And this sort of serves multiple purposes. It allows us to expose the fellows again to this breadth of critical care training that, you know, what you're going to learn in critical care that's going to enhance your skills in the cardiac ICU. But it also allows us to connect those fellows with leaders in the field. And then finally, it lets you see what I think is really a unique feature of this conference. You see faculty learning from each other, and you see that we have this model, you know, we're able to model this excitement of lifelong learning, and that's really prevalent in this particular subspecialty. So I think that it's, you know, this conference has multiple different ways to show trainees how exciting this is, how much growth opportunity there is, and what we, with the right education and how we can change outcomes for patients in the cardiac ICU.
Last question, Dr. Dezfulian, are there any sessions at the upcoming conference that you're particularly excited about?
You know, that's really hard, because I actually I looked at it just today, and I'm excited about the whole meeting, right? So first of all, I mean, I have to say that day one is awesome because it goes through some of the really tough topics, dealing with advanced heart failure, dealing with complications postoperatively, the electrophysiology issues, which are unbelievable in ACHD because of the amount of scar and surgeries these guys have had. That's awesome, but what makes it even more awesome is that I'm going to be sitting in a room of critical care cardiologists. So I think the field of ACHD has been largely dominated by cardiologists, not surprisingly, but they don't have a critical care focus, right? And so they're appropriately interested in the long term and how do we deal with this disease and its progression over time and what's the natural history and what do you do with the Fontan and their liver disease and their their lungs and their lymphatics, but this is very kind of focused on the critical care, that day one of the conference. And that, if you don't get them through the critical care, there is no long term, right? And so it's a big deal. And I love that we're going to be talking about that. And then I'm really excited about the education too, because I mean, not only is this something that Andrea is passionate about, but it's something that for me at my unit has become a necessity, right? Because we are trying to essentially build these adult congenital intensivists, and it requires you to think about what are the skills that you need for that. And I think, that's a unique skill set. You need a background in congenital heart disease. You need to have knowledge of critical care cardiology, and then you need just kind of a broad adult medicine kind of perspective to understand things like GI bleeds and strokes and MIs that are not going to happen in the kids. So whether you're coming from the adult perspective or the peds perspective, there's things to learn. And even as somebody myself who trained in adult and pediatric critical care, I have to say I cared for precious few adult congenital hearts leading up to this job, and that's because they're just not concentrated in one place, right? And so it's really important to kind of have the right training when you're going to be taking care of large numbers. So the whole conference is interesting, but I think particularly day 1 and 2 are going to be awesome.
I gotta say, I think he's being modest. Dr. Dezfulian is going to talk to us about management and some adult congenital patients, and I think that's going to be a captivating talk in particular. So,
thank you. And now I got to live up to that.
Well, I gotta say, this conversation is making me very excited for this, which is coming up at the end of the month. And thank you both for being here. Thank you, Rachel, for putting this together. And again, we're so excited to learn more from each other.